All right, welcome back to part B. Let's talk a little bit more in detail about diabetes, the different types, and then hyper and hypoglycemia. Type 1 diabetes is an autoimmune destruction of the beta cells in the pancreas. This is where the pancreas produces no insulin. This requires insulin therapy. Without insulin, death will occur. There may be wide fluctuations in glucose levels. This type of diabetes is most prone to ketosis, which is the breakdown of fat for energy, and ketosis can change a person's acidity in their blood, their urine, give them a very fruity smell to their mouth. 5 to 10% of all diabetics are type 1. So, very important type of disease, not as common as type 2, which is has many factors. Most multifactorial genetic defects are really what people think, but it's hard to pinpoint, which is why it's so hard to treat. The pancreas still produces some insulin, not enough usually. A lot of times this can be controlled simply through weight loss and dietary measures. Lose weight, eat better, and your type 2 can go away. May not go away forever, but you can have it under control for longer. It may require oral hypoglycemic agents. This is less likely to develop ketosis, and 90% of diabetics are type 2. Now, what are the risk factors for type 2 diabetes? I said if you lose weight and change your diet, you may be able to control it. So, obviously, being overweight with a BMI greater than 25 is one of the risk factors. If you combine that with anything else on this list, such as family history, with genetics, race and ethnicity, genetics, history of gestational diabetes, if you're hypotensive, if you have abnormal lipids, if you have impaired fasting glucose or glucose intolerance, if you're showing signs of insulin resistance, specifically connected to polycystic ovarian disease, if you have a history of vascular disease or an inactive lifestyle, all of these place you at much higher risk for developing type 2. Will you develop type 2? No, there's no guarantee you will or won't. But these are the risk factors. Race and ethnicity, African American, Hispanic and Latino, American Indian, and Alaskan Native Asian American are all at higher risk for developing type 2 diabetes. Gestational diabetes occurs in 2 to 4% of pregnancies. This is hyperglycemia that develops during pregnancy. 30% of women who develop gestational diabetes are estimated to move on to type 2 diabetes within 10 to 15 years. Just something to keep in mind. If any of you have had gestational diabetes, you need to be more careful than other people about controlling your weight, increasing your level of activity, controlling your diet, because those are about the only things you can actually control. You can't change your histories. You can't change your genetics. So control the things you can, and that's about all you can do. Hyperglycemia, hypoglycemia. What do we mean by that? What do we see? Because as nurses, we will always be assessing our patients for everything. So hyperglycemia is the blood sugar more than 126. What might we see? Well, let's think about it. If you have a lot of sugar in your system, your kidneys are going to flush that out. How will it flush it out? It's going to want to make more urine. So you're going to be drinking a lot of water. Drink a lot of water, you're going to be going to the bathroom a lot. You may have dry skin. You may be hungry. You may have blurred vision, drowsiness, nausea. Pretty vague, actually, aren't they? I mean, these could be indicating a lot of things. But if your patient in the hospital is normal one day, and then all of a sudden they just start developing all these symptoms, you might want to think, should we do a blood sugar check? Polyuria, polyphagia, and polydipsia. Those are the 3 polys that go along with hyperglycemia. Polyuria, frequent urination, polyphagia, frequent eating or frequent hunger, and polydipsia, frequent drinking. Now what about hypoglycemia, low blood sugar? We're going to see symptoms that are, again, vague, because they could be applied to many things. So shaking or fast heartbeat, sweating, anxious, dizziness, hunger, impaired vision, weakness and fatigue, headache, irritable. So let's think about this for a second. A person you're taking care of your patient and they have a they normally have a fast heartbeat, and they're sweating, they're anxious. If you put a person on a beta blocker, that is going to control a lot of these symptoms, isn't it? A beta blocker is going to slow your heartbeat down. It's going to take the shaking away, the sweating, the anxiety. A beta blocker could cause dizziness. It could cause weakness. So if a person's on a beta blocker and they have, dizziness, weakness, what's going on? Is it the symptoms of the beta blocker, or are they having low blood sugar? If the person is having low blood sugar, they normally would develop shaking, fast heartbeat, and anxiety, but a beta blocker will prevent those symptoms from being apparent. So again, we always want to know everything that's going on with our patient. Big picture, not just one set of symptoms. So we see our patient and they're displaying symptoms of something. We need to know what medications they're on, what other diagnoses they might have. We need to look at how things interact with one another so that we can properly treat. So how do we treat hypoglycemia? Hypoglycemia, low blood sugar, requires immediate treatment. Hyperglycemia is also very important to treat, but hyperglycemia begins at 126. So if a person is 130, chances are they're going to have no other symptoms than they had at 126. But under 70, people can very quickly develop symptoms. So you need to know how your facility treats hypoglycemia, because every agency has its own set of treatments. But here's some key steps. When you're treating hypoglycemia or low blood sugar, give a sugar source. Do not give insulin. Insulin will only make it worse. So what kind of sugar will we give? Well, we have a lot of options. If they're conscious and able to swallow, we're going to give something with about 15 grams of carbs. So 4 ounces of juice or regular soda, 2 tablespoons of raisins, some saltine crackers, a couple teaspoons of sugar, actually 4 teaspoons of sugar, a tablespoon of honey or corn syrup, 3 or 4 glucose tablets, or 15 grams of glucose gel. Glucose gel looks almost like a frosting tube. This is if they're conscious and able to swallow. If they're unconscious, we're not going to give them anything orally, are we? So then we would give glucagon, either IV or IM, or sub-Q, 1 milligram, or we might give dextrose 50% IV, and we might give 12.5 to 25 grams of that. Now, if you are ever in the situation where you need to give IV dextrose 50%, it is incredibly hard to push because it is really, really thick liquid. Not quite the consistency of syrup, but it's really thick. So it's very hard to push. I'm just telling you that just because the first time I had to give it, I couldn't believe I couldn't believe I was so weak. But remember, conscious and able to swallow, we'll give something by mouth. Unconscious, unable to swallow, we will give something IV, IM, or sub-Q. Because we're going to do this quickly. You have to know what your facility, what their protocols are. At Holy Family, in every kitchen, there is a printout of exactly what you do. If the blood sugar is this, do this. If the blood sugar is this, do this. And it's very, very specific. So know what each facility does and you'll be able to treat hypoglycemia properly. All right, let's come back for the next section on specific diabetic management regimens.